Hi. Hi, this is Mabel Morton. This presentation is on infection control, also called asepsis, and safety for clients through their some terminology that's related to infection, and one of the words is microorganisms, and it's little minuscule, very, very tiny living bodies that need to be seen with a microscope. Pathogens is another word, and pathogens is another name for microorganisms, and it's just any kind of microorganism causing an infection in humans. It could be a bacterial or a viral infection. And then there's also the terminology for normal flora and fauna. Normal flora is like the acid that's in our mouth, mucous membranes, the acid that's on our skin. The skin itself protects us from infection. Types of pathogens. Bacteria is a type of pathogen, and a bacterial infection is syphilis is one. Let's see, a common cold is one. Pneumonia can be bacterial. A virus is influenza and measles. Protozoas are little organisms. Your book talks about them. I'm not going to ask any questions about them. A fungi is the same as fungal infections, so that could be thrush or yeast infections. And the word helminths means worms, so any type of parasite worm. Herpes simplex is a virus, and it does herpes varicella zoster. That's the same as shingles. Influenza, the West Nile virus, is an actual virus. And it's important to understand the link in the chain of infection, because if a nurse understands the link, then they can prevent and stop an infection from spreading. So number one, we have an infectious agent or the causative organism, and that would be, I'm sorry, that would be like the virus itself. Then there's a reservoir or place where the organism grows. So a virus will grow in a warm, wet environment. That therefore it'll grow in a human. The portal of exit, it has to exit the person, and sometimes that's by sneezing or coughing. The mode of transmission is it becomes airborne and flies through the air. The portal of entry means it has to be able to enter another person, and sometimes that's through broken skin or through the mucous membranes when another person's breathing. And there also has to be a susceptible host or person. So the susceptible host or person many times has a weaker immune system and can't fight off. Here that shows the source of contamination is a bacteria that's coming from the sinuses. So we'll say it's an upper respiratory infection. Transfer of bacteria, the sinus drainage got on the hot dog and somebody's eating the hot dog. And you kind of see it develops into food poisoning then. That's kind of a comic picture, but it's the way it goes. Okay, and here's this words I just said about talking about the infectious agents. So you can see the very top of this chain is the infectious agents, and again, it's the bacteria, fungi, parasites. The reservoirs could be people, water, and food. When you think about water, remember we think of stale, stagnant water causes mosquitoes and West Nile virus to multiply, so we think about that. The portals of exit are blood, secretions, excretions from our body, and skin could be the infectious agent leaves the sick person and goes to another. Modes of transmission, and this is where we could do a transmission-based precautions here. They're physical, contact, droplets, and airborne, and we'll talk about each of those in another slide. The portals of entry are how do they enter the healthy person? Will they enter, or a susceptible host? Sometimes they're not healthy. They enter through mucous membranes, such as something getting coughed or thrown into their face and eyes, through the respiratory system, breathing it in, eating it, or through broken skin. And then the susceptible host, many people are exposed to bacteria and viruses and don't get it. The people who could more likely get this are people who have a weaker immune system, and so that's people who have immune deficiency problems, diabetes, patients with burns, and the burns is because all the open skin on them, they're no longer protected, and so they can get an infection really easy. People recovering from surgery, and the very young, like under a month old, and anybody that's an elderly person, say in their 80s. So that kind of helps see that chain of infection. Healthcare associated infections, you'll see them called HAI. We want to avoid those at all, if at all possible. Many times hospitals are getting fined or getting reduced payment when a patient develops a hospital associated infection. And that could be a central line infection, it can be a urinary tract infection. It's an infection they developed after they got to the hospital. We also have primary or secondary infections, and a primary infection would be like the influenza virus was the first one, so it's primary. But then the illness developed on and became pneumonia, and so now there's a secondary infection. That's very common in the elderly, and so they end up dying with pneumonia because they caught the flu to begin with. We have localized and systemic infections, and a localized infection is you cut your finger and it's a little bit swollen and red and it has a little bit of drainage from it. So it's just right there on the fingertip, let's say. And then a systemic infection is it's affecting the whole body now. You're running a fever, your white blood cell counts are going up, and white blood cells are there to fight infection. So they're getting elevated because the body's trying to fight the infection. A fever, heart rate can go up. It's just you see more systemic issues happening. And septicemia means an infection that's through the bloodstream, and that means septicemia or septic infections are multi-organ failure problems that happen with severe infections. And it's something we really, really try to teach nurses, and we want you to be able to identify it quickly also and get it treated fast for these patients. Primary defenses are the defenses that we have that we've been born with, and look, it's the skin. So intact skin prevents us from getting contaminated with blood. Mucous membranes have fluid in them that help protect our eyes. Our mouth has an acidic mucus acidic discharge that helps break down food and bacteria. And then our gastrointestinal system is very acidic, so it really helps prevent infections that way also. The secondary defenses against infection, now this means the infection has now entered the body and now you're having to fight it off. So that's the inflammatory process. So inflammatory process is you feel sick. You feel like you're running a little fever. It could be a high fever, but you're running a fever. Your white blood cells count will go up. You'll see macrophages and the blood cells will rush into that site to try to treat that infection and wash it out. Macrophages will come in and gobble up the infection. Your book talks about it, so you can read it in the book. And the complement cascade is again the blood system that's white blood cells, lymphocytes, and T cells going into the area to fight the infection. B cells and T cells, so this is lymphocytes found in lymph tissue and circulating in the blood. So that they signal the phagocytes to destroy invaders. They have a major role in antigen-antibody response. So I kind of said the secondary ones, I kind of called the B and T cells secondary, but they're not. They're the tertiary. They're the third line of defense. Factors affecting the body's defenses against infection. Factors that affect the body's defenses against infection. Well, being exposed to chemicals can cause you to weaken your body and cause you to become infected. And chemicals can be asbestos. Gosh, you guys can probably think of some also. Coal miners have a coal mine lung because of that, so they develop COPD. Smoking, the age also, the very young babies are more likely to develop an infection. and the elderly, like I said earlier. People with chronic illnesses such as diabetes, COPD, more likely to have an infection, develop infections. People who don't exercise or don't get enough rest. People who have a lot of stress in their life are more likely to get infections. People who have broken skin, and people who have poor nutrition. So, ouch, when you read this, you're like, I better get enough rest and exercise and reduce stress and eat right, and it can help you stay healthy. Hospital-acquired infections, I kind of said a little bit about that already, but the disease Centers for Medicare and Medicaid Services have now ceased to pay for any costs related to 3 common hospital-acquired infections, and that is catheter-associated infections from urinary catheters, infections in the blood due to central vascular lines, and infection in the chest incisions after open heart surgery. So it's very important that we take good care of these patients. And as you move on through nursing school, we'll show you the protocols on them. The catheter-associated infections is like 57 pages long, and it all boils down to remove Foley catheters as soon as you can. Don't put them in unless you have to. Standard precautions. Standard precautions are a group of safety measures performed to prevent the transmission of pathogens. So standard precautions are what we use on every single person. We consider every person in the whole world as possibly a person that has pathogens that's going to transmit an infection. So we use them on everybody. And so that is washing your hands when you enter and leave the room, wearing appropriate protective equipment if exposure is possible, and using a cough etiquette. And the CDC talks about the cough etiquette. And that I won't play the video for you. You can go on it and find it. But the cough etiquette is coughing into the antecubital area of your arm, so that you're not coughing in your hands and then touching. With standard precautions, it's gloves, gown, and mask, eye protection, and a face shield. We always have to have puncture-resistant sharps containers anywhere we might have a needle also. And see the little asterisk beside all of those? We wear these when there's a risk of contact with blood or body fluids is present. So we use protective equipment. We call it PPE, personal protective equipment, if we're likely to come into body fluids or blood. So as a nurse, we think about what procedure am I going to do? What am I going to be exposed to? If I'm going into a room and going to put an NG tube down a patient, I should put a gown on the front. I should wear a gown, and I'm definitely going to wear gloves. If I go into a room with a patient that has C. difficile is a really serious gastrointestinal infection, I'm going to wear gown, gloves, and really wash my hands with soap and water each time I enter and leave that room. Remember when we were looking at the chain of infection and I said, this is the transmission one? Well, this is the piece where we can break the chain of infection. So, used when a patient has a communicable illness that's spread through contact, respiratory, or droplets, or anything in the air. So, transmission-based precautions are used. Let me just get into each slide individually. It'll probably be easier to talk about it that way. We wear gowns, gloves, mask, eye protection, and sometimes head covering. We use this whatever is appropriate for the situation we're about to walk. Contact transmission-based precautions, and you can click on this link to the CDC and it's going to take you to it and read that because it's really interesting. The type of illnesses we'll come into with that is C. diff, MRSA, shingles, and in this one we wear glove and gown every time we go in the room, and we wash our hands every time we come in or out of the room. The airborne transmission-based precautions, these are very fine, very, very tiny, fine let's not call them droplets, let's call them mist of body fluid. So airborne based precautions, again, go to the CDC website. The types of illnesses that we would use this for would be if we were suspicious of the patient having tuberculosis, measles, or chickenpox. we would start, as nurses, we would institute airborne transmission-based precautions. And almost all of these transmission-based precautions, it's nurses that say, let's do it. And we have to do it before we even get the tests, because it may take us 6 days, sometimes 6 weeks, to have the results back on these borne particles that are heavier than a fine mist, okay? And again, there's a link for it, and that would be influenza, so you need to wear a mask. And the link is great, and we'll look at it in class too, but the link is great because it'll tell you how far away you need to stand from the person. And when we're in isolation with these patients, we try to do our work. We're in clumps of time, so I might go in and strip the bed, give them a bath, give them their medication, do the head-to-toe assessment. So I might take care of the rest of the patients first. Again, it depends upon if this patient's really sick, then that's going to be the priority based instead of worrying about coming and going out of the room. These patients feel very isolated and they're lonely. So you need to give them things to do that'll help them occupy themselves. They could read books. There's games. There's a radio. Most of the hospitals will have an activity department with a radio, DVDs. They can use their computers. Most hospitals have internet access for free for the patients. Of course, let them use the phone and talk to their family. They can have visitors, but the visitors need to follow the precautions too. And as a nurse, you're just going to have to talk to the visitors. Sepsis. So medical asepsis means to remain clean. So we wash our hands. So hand hygiene is washing our hands, and we should wash our hands for 20 seconds. Be sure and remember that, because you'll see a lot of exam questions asking that. But 20 seconds is what the Kansas Board of Nursing says for the IV class, and it's what I found on the CDC site. Part of also maintaining medical asepsis is to keep the patient's room clean. So if the patient sets their urinal up on the counter, remove it from the counter, dump it every time it gets any urine in it, measure it and dump it, and then hook it to the bed frame. Try to encourage them to not sit it on the tabletop where they're eating. We use standard precautions, which means we're going to wear gloves or gown or mask whenever we're going to get into body fluids. And we'll also follow, in medical asepsis, we follow transmission-based precautions if we're suspicious that the patient has one of these infections that's going to need a transmission-based isolation. Things sterile. So it's maintaining a sterile environment and such as what's found in operating room. Sterile technique is performing procedures in such a way that no pathogens will enter the patient's body when inserting tubes or giving injections. So we'll do some of the sterile technique at the bedside, and I'm telling you, ladies, we'll teach you this in the first, I think it's by week 2, we're into doing it. So inserting tubes and giving injections need to be done as a sterile technique. Nurses' responsibilities for asepsis is keep the room neat, clean, and free of clutter, put away any unused or unneeded items, keep the needed items close at hand for the patient, like their telephone and their walker, things like that, so they don't fall trying to get to them. Empty their urinals, bedpans, and bedside commodes immediately after use. Don't leave them leave them on the bedside table with food. Don't throw foul odors into the trash can. It's fine to throw it in there, like a dirty dressing or toilet paper, but take that out with you when you leave the room. Keep the environment odor-free and pleasant, and wash your hands as required. Use hand hygiene. When do you wash your hands? Wash your hands after touching blood, body fluids, secretions, any excretions, or any contaminated items. Immediately wash your hands every time you remove your gloves. Every time you enter a patient's room, wash your hands. Anytime you're between caring for 2 patients in the same room, wash your hands then also. If you're feeding patients at a table and you're feeding 2 patients at a table, you want one hand to be feeding one patient and the other hand to feed the second patient. You cannot mix your hands together without cleaning your hands. When you arrive on the nursing unit, you should need to wash your hands after returning to the nursing unit from break or meals, after you use the restroom, and anytime your hands are visibly dirty, wash your hands. Let me say a little bit more about hand washing. The CDC says that the alcohol-based hand cleanser is better to use than soap and water. They've done some studies on that, and they say the reason they say it's better, it's not necessarily that it kills all the bacteria, but it's the compliance rate is so much higher with that. So we're much better off using that. We have to use soap and water if we're dealing with a pathogen that has spores, and that would be C. diff has spores. I can't think of anything else that has spores, but if somebody has C. difficile or C. diff, you have to wash your hands with soap and water. You can't use the alcohol-based cleaners. And caring for patients in isolation, and I've talked about this a little bit. Spend time talking with the patient while you're in the room. Ask them if you can bring them anything like newspapers or magazines. Avoid expressing distaste regarding their diagnosis or having to enter an isolation room, because it's irritating to us nurses to have to put on all of this clothing and stuff for isolation, but don't let the patient know that, and we need to change our attitude about it too. Remember that the patient is a person first and the diagnosis is secondary to their needs. Factors contributing to unsafe patient environment. So an unsafe patient environment, what I mean by that is patients who are likely to fall or get injured in their room. The older they are, the more likely they're to get injured, or if they're confused and cannot understand what you're saying, they're more likely to get injured. And then when I say age, it also, you guys know this too, children under the age of like 4 are likely to get injured, also falling out of beds and off furniture. Anybody with impaired mobility is likely to be injured because they're more likely to fall. People who cannot communicate, have a communication problem, are likely to fall or be injured. And anybody in pain and discomfort are likely to fall and be injured. They're higher risk for this. Anyone that's delayed assistance, let's say they're way down the hall and it's going to take you 10 minutes to get there, or they call you at the time when you're all tied up feeding patients. And then people that have to have a lot of equipment to drag around with them, like IV poles and, let's see, we sometimes will have 2 IV poles, a walker, and trying to pull all of that with the patient. Say a Foley catheter, the more equipment, the more likely they are to trip and fall. Joint Commission is the accreditation agency for hospitals, and they have written national patient safety goals that every hospital and every nursing home in the country follows. And so this is considered the standard of care since it's followed by everybody, and it's been set up as a national goal. It's important that we always identify patients correctly, and we have to use 2 methods. It can never be the room number. It has to be the patient's name, date of birth, or it can be their name and their picture, but it has to be 2 methods. The other goal is to improve staff communication. So we have SBAR now, and we'll talk about SBAR as we go through this course. But we have to improve our communication, especially when we're giving report and going home, or when we're receiving report from transferring a patient from a nursing home to a hospital or from the operating room back to the hospital floor. One of the other goals is using medications safely. It's very important that nurses look at the medications and know why the patient's taking it and if this dose is safe. Preventing infections is another goal, and they're looking at specifically urinary tract infections, central line infections, identifying patient safety risks, patients that are likely to fall, they want us to catch those. Preventing mistakes in surgery. So we have specific plans that we follow, or protocols that we follow. Preventing mistakes in surgery is like the timeout. Before we do the surgery, we stop and say, we'll talk about it as we go on through the course, but we will talk. There's a specific protocol that we follow. Fires in facilities. Look at this RACE. Rescue, alarm, confine, extinguish. RACE. If you remember the word RACE, you'll remember what to do in a fire, hopefully. The very first thing you have to do is rescue the people in the immediate vicinity of the fire, and then pull the alarm. Then confine it by slamming the door shut, shutting the door so the fire cannot spread as quickly down the hall. And extinguish the fire if the fire is small enough. And I've had firefighters say, you can extinguish it if it's still in a fire that's still burning in the trash can. Once it's traveled out of the trash can, don't try to extinguish it. Just get out of the room, because you're going to waste time that could cost a patient or you their life. Fires, don't try to, I just told you that. The acronym for PASS, so how to handle and how to use a fire extinguisher. Fire extinguishers are long red barrels, and they have a like a handle on them with a pin in it. So pull the pin that's found between the two handles. Just give a yank on it and yank it out. Aim the nozzle of the fire extinguisher at the base of the flames. And people tend to want to shoot the top of the flames, but don't do that. Shoot the base of the flames with it. Squeeze the handles together to release the contents of the extinguisher, and sweep the nozzle back and forth at the base of the flames to extinguish the fire. So do you see the acronym PASS for that? There's a type A, which is for paper and wood. Type B is combustible, such as oil and gasoline. C is electrical. And D is powders and shavings of combustible metals. And type K is kitchen fires due to combustible liquids such as oil and fats. I probably don't have any exam questions on that, but try to remember this. A is for wood, B is oil, and C is for electrical, because the state exams will probably have these type of questions. Tornado procedures. When there's a tornado watch, most facilities will have a policy for you to follow, and the policies that I have seen is what I wrote here on our PowerPoints. A watch is close the drapes between the beds, close the drapes at the windows, close the blinds, gather blankets, pillows, and flashlights, and put them all on one cart so that you can take them down a hall wherever you're going to evacuate the patients, and listen to the weather report. So at this point, we've got everything wrapped up and ready, but we're continuing on our day like we normally would. Listen to the weather report, and as a nurse, you can't sit and listen to the weather report, but I've had patients many times that were really with it, and the patient will listen to the weather report for you and then put on their call light if a storm is coming close. The local fire department and police department says they'll call the nursing homes and hospitals to tell them if a tornado's coming. I've had them not call before. So I just use my own common sense and do what I need to do. A warning is immediately take the patients to safety. So you'll have to follow the policy and procedure of their facility. Some of them will say take them in the hallway. And I've had firemen say don't ever put them in the hallway because the fire just shoots like a tunnel roaring down a hall. But hopefully that's not the policies in the places anymore. Most tell you to in a tornado, take the patients to their room and keep them in their room. Go into the bathroom with them where there's no windows. Now, I've had some have an internal, like, x-ray area where there's no windows at all, and I've had some hospitals say, bring all the patients to this room and shut all the doors in the hallway. And you know what? When we get to a watch, if the storm looks like it really is moving right toward us, I go on and shut all the doors in the hallway also. The parents, and there's this PowerPoint here tells you to go click on this link and it'll show you. The big thing is there'll be a code for an infant abduction through the facility, and they're going to want all the nurses and staff to stop anybody that doesn't belong in the building. I shouldn't say stop. They want you to look at them and see if they're carrying a bag or something, or carrying a baby. And they don't really want you to stop because the person will usually become violent if you stop them. But we don't want this person to leave the building. And most facilities, the doors will lock down when this alarm goes off that a baby's been abducted. And you guys know this too, I'm sure. But most facilities now have alarms on the babies, so the door won't even open in the nursery area if a stranger tries to get in. They can't get in at all, and they can't. It just won't open. Even us nurses can't get in without our own pass card to get through there. Let's see, what else does it tell you? In the case of an abduction, the FEMA suggests that we leave the rest of the babies in the hospital, leave them with their mothers, because there's nobody that's ever going to protect that baby's life like the mother will. So leave the baby with the mother in the room. Don't take them to the nursery. Again, you'll have to see what the policy is wherever you're working, but that's what FEMA says to do. Person that gets in the building. Number 1, don't fight or come in contact with this person. Call security or the police. Get a good description of the person and the automobile. These people come in and want to argue, or they come in and want to get drugs from nurses. Just don't argue with them, and walk away as soon as you can and call the police. How about a bomb threat? We can look at FEMA, our federal government's policy, and these are people that will generally call you on the phone and tell you there's a bomb in the building. So you want to keep them on the phone. And the best scenario of all is you nudge another nurse and she calls the police and tells them there's a bomb threat, and the nurse has got them on the phone so that way they can tap your lines. I don't know if that's really possible. I can just tell you I've seen that as the policies in most of these facilities. So keep them on the phone. Ask them why they have a bomb threat. Why are they doing this? Because they probably have a personal vendetta against the hospital or one of the staff members. So if we can ask them why, the police and the facility will be able to figure out who it is. Listen to the background for noises. If you hear a train whistling in the background, then that gives you an idea. Or do you see what I mean? It gives you an idea. And again, get a coworker to call the police for you. Here's about 8 strategies that I could think of, and you guys can probably think of more. I was working at a facility once that had 50 interventions that we could take to prevent someone from falling. And as nurses, we pick the interventions that are specifically suited to that patient. So number 1 is place the patients in a room next to the nurse's station. Put them close to us so that when the alarm goes off, we can hear them. Stay with the patient when they're in the bathroom. If the patient's a fall risk, don't ever leave them on the toilet. And I know people do that, but don't do it. Keep the bed at the lowest the lowest level. Place the the overbed table across the wheelchair. Yeah, and I know some places would say that's a restraint, but you know how that goes. I'd still do it and give them some stuff to mess with. Offer regular opportunities to toilet, because sometimes they're trying to get up and because they need to toilet. Bed and chair alarms in some of the places are still using bed and chair alarms, and they can help a lot. Call lights and the phone should be close to the patient so they can call for help. And provide back rubs and distractions for the patient. And you guys know, sometimes folding towels, reading magazines, sometimes calling the family and having a family member sit with them. I know my mother-in-law fell 4 times one time in one morning because she was so agitated, and she had a urinary tract infection, was very agitated and confused. And the girls called me and apologized for having to call me, but they needed me to come and sit with her. You know what, you guys, they shouldn't have ever apologized, and that's what I told them. Of course I'll come and sit with her. I wasn't working full time, so yes, I went up there and sat with her, and she didn't fall at all rest of the day. Not because I did anything special, but because I could stay with her the whole time and talk to her and just be loving and good to her. And she knew she was confused, and she admitted to being confused. Most of our facilities, and you see this PowerPoint is talking about the history of falling, is worth 25 points. A secondary diagnosis, let's say your patient's admitted with chest pain, but they also have pneumonia, or they had an MI, so there's 15 more points. An ambulatory aid, such as a cane or a walker or a wheelchair, is, no, well, it wouldn't be a wheelchair. Ambulatory aid would be a cane or a walker, is 15 or 30 points. If they have an IV pole and an IV pump, or if they just have a saline lock, there's 20 points. I really think they really meant IV pole, but I can tell you that some of the facilities do say even a saline lock is 20 points. If they have trouble with their gait or transferring, it's 10 or 20 points. And the mental status, if they're confused off and on, then that's 15 points. And I'm flipping to the next screen now. 0 to 24 points means that we need to implement a level 1 preventative fall precaution. So they're a little bit, they might fall. They're low risk. 25 to 50 points, when we added those up, is a level 2 fall precaution, and greater than 51, implement the level 3, you guys. And I'll have the forms when we do this in class. We'll do this activity together in class. And I don't want to do that activity right now, because we'll do it in class, and you'll hold up your cards to give us the answers. Give me the answers. So I'm moving past the second one up to the next, to the responding to individual emergencies. Nurses need to be able to do CPR, and you've all been trained in that. The Heimlich maneuver, and you know what that is, coming up behind the patient, putting your hand in, putting your hand into a fist and putting one hand over it, and then pushing up and into their under their their upper abdomen to make them cough up something. Don't only do that Heimlich maneuver if the patient cannot talk. If the patient can talk or coughing, don't do it. Let them cough their stuff up. And then first aid certification is something that nurses do. As an LPN, you'll be trained way past first aid certification, but people can be. And the code blue was mentioned in our information, but code blue is really means a patient has died and we need to resuscitate them. And most hospitals aren't using codes anymore. For years, we used a code so the patients wouldn't get excited and upset knowing that something was wrong. So they'd call a code yellow or a code red or a code blue. But too many people didn't know what the code meant, so now they just say a fire has been located in hall such and such, or resuscitation is needed in room such and such. Here's showing you how to do abdominal thrusts, or if you're alone, you can lean over a chair and do the thrust. And guidelines for responding to a mass casualty event. We will use if we ever had to do this, they always set these up as a disaster triage model, and the triage means they're going to treat the most likely to survive first. So the most seriously ill but likely to survive will be treated first. The patients that are likely to die, no matter what we do, they will be treated last. And so many hospitals, I was going to say all the hospitals have to have a plan, and they practice it probably once a year. They practice this mass casualty event plan. And when I've been in nursing homes, they don't practice it at all, and they think it won't affect them. But here's the plan from the hospital point of view. The first thing, if there's a mass casualty event, let's say a tornado hits the town, a massive flood, a school bus has a wreck, and they bring in 35 patients, the first thing the hospital does is the nurses on the floor have to call the doctor and get dismissal orders on anybody that would be safe to be transferred to a nursing home. So if we're a 24-bed hospital, we might send out 20 patients within 2 hours and get them all sent to the nursing home. So the hospital nurses, the long-term care nurses will have a lot to do as they get these 20 patients admitted. And you can see, if that's the case, one nurse at the nursing home cannot admit 20 patients or 10 patients each. So they're going to have extra staff come in and help in these emergencies. And that puts a lot of stress on the nurses, because the nurses are like, no, I want to stay home with my children. No, you need to come in and help. And to me, bring your children with you if you can. I don't know. We have physical hazards. So bodily injury from patient care and repetitive motion, such as back injuries, are really common for nurses. Gosh, what's the name of it? Gosh darn it, you guys. OSHA. OSHA says that the number one employer, the highest risk job of all is construction work, and nursing is second for back injuries. So really a lot of back injuries for nurses. Chemical hazards are another workplace safety issue, and we are exposed to cytotoxic medications. So you will see medications that say do not touch with your hands, or if you're pregnant, do not touch these medicines. And that's generally medications that are for the male for prostate cancer. But we also have chemotherapy and other drugs that can cause a lot of harm if you touch them. So we also have biological hazards, exposure to contaminated blood and body fluids, and needle stick injuries. On needle stick injuries, let me just say, don't ever recap a used needle. Used needles need to be put in a sharps container. Don't recap them, because sometimes the needle pokes out the side of the cap and can stick the nerve. Contamination needle sticks. If this happens to you, wash the area with soap and water immediately. That's the very first thing to do. And then tell your supervisor. And then from that point, follow the policy and procedure. Make sure you fill out an incident report, because many times the insurance companies will not cover any of the cost if you don't have an incident report filled out before you leave your shift. You may need to have hepatitis labs drawn, and you may need to have HIV labs drawn. Some places will just send you to the emergency room if this happens. Influences contributing to an unsafe practice as a nurse: lack of rest. If the nurse is tired, abuse of alcohol leads to unsafe practice because you're intoxicated or you're hungover. Use of some prescription medications, such as pain medications, can cause an unsafe practice. and use of illegal drugs can cause an unsafe practice. Another thing that can cause problems for nurses is exposure to radiation. Wear a lead apron during procedures involving X-rays or fluoroscopy, and even wear the lead apron that reaches up to your neck to protect your thyroid gland. Wear a film badge if you work in radiology on a regular basis, and limit amount of time spent caring for patients that have implanted radiation. So sometimes when we're treating patients that have cancer, they can implant a radiation device inside the patient, like their uterus or their bladder, and they'll leave it in for a few days, and we'll take care of them on the hospital floor. If that's the case, spend very little time with them. And when we get into the chemotherapy and cancer treatments and discussions in the last semester of the program, we'll talk about that. Don't care for these patients that have radiation exposure if you're pregnant. Understand the location for the center of gravity and base support. So the way to transfer patients, and you will see this in the reading material and the ATIs also, always stand with your feet wide apart. Keep your feet shoulder width apart. Plan your work carefully to do it safely. Elevate your work to a comfortable level. So when we're taking care of a patient in bed, we need to raise the bed up so that we can get to the patient easily and not hurt our backs. Avoid twisting. Don't twist and lift at all. Bend your knees when we lift heavy objects. Carry objects close to the body with the elbows bent. Push, pull, or slide heavy objects instead of lifting them, and get help when you need to move a patient. Don't try to move one yourself. Now let's talk about restraints. Okay, so bed and chair or leg monitor can be used. So these are restraint alternatives. So we can use the alarms or the monitors, so that I've even used baby monitors so we can hear the patient moving around in the room. We can use soft devices, and we can use strategies such as rotating people in to watch the patient. So that's restraint alternatives. The chair, bed, and leg monitors or soft devices we have used in the past, and we don't use them very often, but vest restraints, waist restraint, extremity, and mitt restraints. And we would use these only in the case of a patient trying to harm themselves, or going to cause harm to themselves, or they're going to harm somebody else. So we have to always, let me flip the slide and get information. We always try other options and document everything you tried before you go to restraints, because restraints can cause you to be sued, you and the doctor. So always try everything else. Everything else means a phone, doing whatever they want to help them be comfortable, pain medication, anxiety medicine if they need that. Not to snow them, though. You can't snow them and knock them out, because that's considered a chemical restraint. A visitor, family with them, one-on-one with a nurse's aide with them, we might have to try that. But if we're going to use a restraint, we have to get a doctor's order, and we have to check the patient every 30 minutes. So the nurse's aide could go in and check on the patient every 30 minutes for you, and we have to remove the restraint every 2 hours. That means removing one hand, or it means loosening it so that they can move their hand and wrist around better. It doesn't mean removing both at the same time and then running down the hall to try to capture them. Document all actions on the appropriate flow sheet. You have to have documentation to prove you did all of this. The nurse themselves would need to be the person who checks the patient at least every 2 hours, then looks to see and removes the restraint. She's going to have to look to see if they have good circulation past the point where the restraint is at, because restraints have been known to have killed patients before, because they've strangulated with them, sliding them through a vest restraint, or they have damaged their wrist and hands to the point where they couldn't use them again, damaged the nerves in them. Another safety issue, and this, in 1999, the IOM did a report that amazed the whole country, including nurses. And the report was called "To Err is Human." It's building a safer healthcare system. And they said 98,000 patients die each year from a medical error that nurses and doctors make. Medical errors kill more Americans than breast cancer, motor vehicle accidents, or AIDS. 7% of hospitalized patients experience serious medication errors. So look, a lot of them are medication errors, and that's too bad. And out of those, Most of them that die are caused by medication errors or the wrong diagnosis for the patient. The cost is $8 to $29 billion every year. And so the Institute of Medicine has spearheaded an initiative to improve quality care. So they put together a bunch of professionals, scientists, doctors, and nurses, and they started looking at what's causing our mistakes, what are the problems, and then coming in and designing a system that gives safer care. Today, the electronic medical medication MARS systems that we use is because of that IOM report when they said this is how many errors we're having. We're like, wow. Medication errors are a big issue for nurses. We'll talk about this more in the course, but medications must be administered using the standard of care and checking the medication 3 times before administering it. Nurses that administer medication must know the normal dose and what the medication is used for, and then think about that medication to ensure that it's safe for this patient. Just because there's an order to give it, there's a lot of times we don't give it. We go back and call the doctor. Let's say in situations we'll see this in is we'll have medication for blood pressure, and the blood pressure is low. Well, then don't give the medicine. Call the doctor and talk to them. Or a lot of times we'll wait an hour, and we'll get into this more when we get into medications. We'll wait an hour and recheck their blood pressure. Joint Commission. So look, this is again the snapshot of the safety goals. Not all of Joint Commission safety goals apply to hospitals. For 2007, credit to hospitals must comply with the following 8 goals, and it's improve the accuracy of patient identification, 2 identifiers, caregiver communication, safety with medications, reducing the risk of hospital-acquired infections, accurately and completely reconcile medications across the continuum of care. When a patient's admitted, we're making sure that we have the right medications through the doctor's office and the pharmacy, and we check it with the patient too. Reduce the risk of patient harm resulting from falls, encourage patients' involvement in their own care, and identify safety risk inherent in your patient population. Look at this, you guys. So here's the nursing process, and you'll write so many of these, your head will swim. But this is the nursing diagnosis. So our nursing diagnosis here is potential for falls related to confusion as evidenced by unsafe mobility. The goal, we want our patient to not fall this shift. Okay, so the interventions are, what am I going to do to prevent that patient from falling? So in this patient's case, I said I'm going to put alarms on the bed and chair, have the patient's room near the nurse's station, toilet after every meal and upon first awakening, keep the phone and the call light near the patient, and assess for urinary tract infections. And at the end of the shift, I have to look to see and evaluate my goal. The goal was met because the patient did not fall this shift. So do you see how this looks a little confusing, but this will be so simple, and you'll love this by the time you finish nursing school. I'm hoping that you can understand this system pretty fast, because this is what we'll be teaching all the way through school. This nursing diagnosis, goal, interventions, evaluation. That's what we'll. Procedures for handling waste. It's important that we put infectious material in red biohazard bags. Each facility has a policy for this. Some say any drop of body fluid, or others say if the body fluid can actually drop off a cotton ball, then it has to be put in biohazard bags. Just follow the facility policy. We must carry all linen and trash bags away from our uniform. Don't drag the bags down the hall. Carry them and dispose of them correctly. Don't sit on the patient's beds. You can easily obtain an infection or parasites doing this. You can also then transmit the pathogen to other patients' rooms. Don't sit on the bed even if the doctor sits on the bed. And I know I've seen the doctor sit on the bed. I'm like, what? I don't say anything, but don't. Okay, so here we go for the MSDS. This MSDS is a material safety data sheet. So it's a data or information about every single chemical that's in a medical facility. Even the whiteout has to have an MSDS sheet on it. And most of the facilities will have a computer program that the nurses that work there can type in and pull it up. So that The MSDS tells us what to do in case of contact of this chemical with the skin, eyes, or swallowing it. It also tells us the flashpoint for fire or inhalation problems. It has cleanup procedures listed. So do you see, I won't go into a lot of detail with it, but it'll tell us like the health hazard. This drug is, let's say, one of the biggest ones that I see, you guys, is the acidic cleaners that we clean the bathtubs with, and it says let them sit for 10 minutes. If you've ever read the MSDS sheet on that, you're going to be like, oh my God, it's considered a 2 or a 3 for a health hazard. It tells you to spray the chemical and get out of the room for 10 minutes. Don't stand there and breathe it. It's irritating to the respiratory system. And then see the other issue on this says the fire hazard. That'll tell you if it's a flash point of 2 or 1, 3 or 4. And flash points would be, I mean, good grief. You know what I'm saying? Flash points means it's going to shoot off into a fire. And then it'll also have the specific hazard, whether it's radioactive, use no water, if it's alkaline or acidic, and then reactivity. It's going to tell you if there's a violent chemical change or if it may detonate and become like a bomb. This nurse is fine. We'll find, oh gosh, what would we find, you guys? Somebody might spill bleach on the floor, and bleach is considered caustic. It shouldn't be on the floor and it shouldn't be on people. So spills such as bleach can be cleaned first by soaking them with paper towels. This is what I usually see for policies. You be sure and put on your gloves and pick up the towels and the chemical. Dispose of the material in a safe manner, and it may tell you to put it in biohazard. The MSDS will tell you how to dispose of it, though, when you read that data sheet on that chemical. And then clean the spill site to remove all residue. And again, it'll tell you what chemical you're going to have to use. It may say you're going to have to get a hazmat team come in and hose it down with a fire hydrant. A fire truck hose, God help us, but that's kind of things that we'll do. I've never had any of that kind of stuff happen, so that's a good thing. Home safety evaluations. Physical therapy and nurses help patients have a safe home by educating and conducting a home safety evaluation. They look for very specific things, like they assess the patient and say she's going to have trouble walking on stairs, or she's in her home, she has 4 stairs, so before we send her home, we're going to have to make sure she can ambulate these stairs. So they'll go to the house and they'll look for, is there any loose rugs that might cause the patient to slip and fall? They're going to look to make sure the patient has a phone that works and they have utilities on in the house. And so there's a home safety eval checklist, and sometimes the students at our hospital anyway, if the physical therapy needs to go to their home to do a safety eval, my students have gotten to go with them to see how to do it, and it's kind of fun. It is fun. So let's see here, you guys. Again, we're doing the same thing we did a while ago. The patient's problem or the nursing diagnosis on this one says potential unsafe home related to repeated admissions and falling. So this patient's repeatedly falling and having to be brought back to the hospital. But our patient wants to go home, and she's willing to have the home set up so that she can be safer in it. That's our nursing diagnosis, potential unsafe home. The goal is, I want this patient to be able to go home. Patient will have home set up for safety before discharge. She's going to let physical therapy go in with her and set up her home, right? Interventions. Here's our interventions. Scatter rugs are not around. No extension cords across the floors. No rugs over the top of extension cords. That's a fire hazard. Clear the pathway to walk from the bedroom to the bathroom at night. There needs to be a lamp or a light switch near the bed. There's grab bars in the shower and the bathroom. So the evaluation of the goal. So here we go. Goal was not met in this case because the spouse does have workers coming within the week to fix the cords and lights and scatter rugs. So they went out and did to the home eval, and they'll tell the family what needs to be done. The family has to go hire the workers to do it. So that hasn't been met yet, but they'll get it met, and then the patient will be sent home after this situation is set up correctly for them. But you guys have already seen this, or anybody that's worked in a hospital knows, if the patient's of sound mind and competent to make decisions, even though it might be a horrible decision, we send them home anyway. We won't like it, but we can't Disaster Management Plan Team. The LPN's role internally, the LPN cares for the non-critical patients and dismisses patients to long-term care that can safely be dismissed after getting orders. The long-term care nurses should expect and be prepared for hospital transfers. And externally, if you're at home, plan to come to the facility to help. Many facilities will make it mandatory, but be ready to help the community. Even if you can't help the facility, be ready to help the community. And you can also join the emergency management team in your state and in your county. And what is disaster management? It says preparedness. Activities prior to a disaster, such as have a preparedness plan, emergency exercises and training and warning systems. Preparedness means having fresh water, like stored in your basement, extra food. They say to keep like 3 days worth of food, 3 days worth of water stored. And then the response. Activities during a disaster, there should be public warning systems, emergency operations, and be ready for search and rescue. And the recovery stage. This is activities following the disaster. Temporary housing will need to be set up, claims processing and grants, long-term medical care and counseling set up. In mitigation, activities that reduce the effects of the disaster. This could be building codes and zoning. They're going to look at what can we do to improve so that this doesn't happen again. Vulnerability analysis, like is there a certain population that needs more help? And then public education. Remember to not alter the alarms. You guys, I'm truly amazed at this, but there are nurses who will go into the machines, like vital sign machines, oxygen saturation machines, and turn the alarms off. The IV pumps, they turn the alarms off, turn them so low so that they don't wake up the patient or bother the nurse. Don't do that because that can get you sued. You're responsible for knowing how to safely operate the equipment that you use. And the common equipment that we use are beds. And I can show you how to use the electric beds in our lab downstairs. But when you get into your hospital, make sure you know how to use those patients' beds. The vital sign monitors, you've got to safely know how to use walkers and canes, how to use the bathtubs, showers, braces, and immobilizers. We won't have you giving showers to the patients. You will do baths in the bathtubs. I'm sorry, let me restate that. You will give showers, but you won't use the bathtub with the patients. You'll do bed baths with the patients. And lifts, the whole body and sit to stand lifts. Don't use these while in clinicals unless the staff, hospital, or facility staff member is with you. We would rather they used them and you watch them because every facility writes their own policies of how they want that equipment hooked up and used. And you guys, it can be the same equipment in the same facility, and I know what the manufacturer says to do, and the facilities aren't doing it. So we don't want you to use that equipment unless the facility employee is with you and they're using it and you're just standing there watching them. If you don't know how to operate any equipment, then you have to ask. Never use any equipment until you've been taught, but don't use those lifts at all unless the hospital employee or the nursing home employee is standing there with you.